Oh, how are you?
I'm so happy that you were able to join us today and give us some information about what you're doing and how you're helping lupus patients all across the world. So, do you want to give us a little synopsis of what you do and who you are and give us a little bio?
Yeah, for sure. So I'm Dr. Blazer. I am a rheumatologist at NYU Langone Health, and I specialize in lupus, and particularly lupus as it affects people of African ancestry. So I think many of us know lupus is much more common and tends to be more severe in people of African ancestry across the globe, and yet lupus in people of African ancestry tends to be understudied, and treatment options tend to be more limited, especially when people can't necessarily afford to either get care or to engage with the treatments that we have. So what I do is I study the pathogenesis of lupus and how it might be different in people of African ancestry, then also look at some of the structural factors and socioeconomic factors that might worsen disease or increase the risk of exposures that worsen severe outcomes.
Wow, that's important work. That's important work that often gets pushed to the side and unknown mostly.
Right.
So I'm glad that you're doing that. That is awesome. That really helps because a lot of lupus patients don't go through the whole different stages to get, their lupus under control, or they're not even afforded the opportunity to see a doctor and things like that in different areas. So awesome. So I know you have a specific program that you're going to actually show us, a PowerPoint presentation.
Yes. Yeah, so I have a few slides here that will talk about structural racism in lupus, and then I'll make a little plug for my global studies in lupus, and then we'll get into the questions thereafter. If that's
all right. All right. So let me get this. Let me get your let's get that up for you. Let's close that down a little bit. Okay, there we go. All right, here we go. You just tell me when I need to click.
Sounds great. All right, so thank you and welcome everybody to this presentation. I will be talking about structural racism and lupus. Next slide. Right, so I'm sure in this audience, people know what lupus is, but, oops. Uh-oh.
Did I go back?
Yeah, good. Yeah, maybe. There we go. Okay.
That's it?
Yes, that's good. That's good. Yeah. So just as an overview, lupus is a multi-organ system autoimmune disorder. And what I mean by that is lupus is a disorder of the immune system where instead of the immune system protecting you against viruses or bacteria, it starts to become active in your own healthy tissues. Now, white blood cells are the cells that propagate lupus, and that means that anywhere the blood can go, lupus can go. So as you can see in the diagram to the right, lupus can affect the blood, the skin, the joints, the brain, the kidneys, really anywhere. And it really makes it a little bit difficult to diagnose because we have sort of two buckets of symptoms related to lupus. So anyone who's had a bad flu, or anyone who's had some sort of an infection knows that when your immune system is active, you might have fever, fatigue, weight loss, and that's the case with lupus as well. But then you also have symptoms due to how lupus is affecting the body. So if it's affecting the skin, you might have a rash. If it's affecting the joints, you might have arthritis. If it's affecting the kidneys, you might have nephritis, right? So because no two lupus patients look alike, we call it the great imitator, right? So it can look like many different disorders. The characteristic blood tests for lupus are based on testing for the antibodies, the autoantibodies, which are the proteins that the immune system or the white blood cells produce that are targeted against your own healthy tissues. So that's the ANA test. Next slide, please. So what do we know about mortality in lupus? So this is a study that was published in Arthritis and Rheumatology in 2018, where authors looked at the top 10 causes of death for young women. They excluded things like accidents and physical deaths. And what they found was that looking at decades 15 to 24, 25 to 34, 35 to 44. In the youngest decade, lupus was a top 10 cause of death for all women. But then when they look at the subset of women who were African American or Hispanic, they found that lupus remained a top 10 cause of death into the 4th decade of life. Next slide. Yeah. Now, patients ask me all the time, is lupus genetic? And I know that we all focus on this. So I want to talk about the incidence and prevalence of lupus. And then I also want to talk about some of the genetics of lupus. So in our most recent incidence data, we found that lupus is fairly common of an uncommon disease. So 5.5 per 100,000 people develop lupus in a given year. And when we look at prevalence, it's about 72.8 people per 100,000 people are living with lupus. Now, when you look at African American women, it's actually 1 per 537, and that's actually worse for Afro-Caribbean women. So it's about 1 per 250 women. When I'm saying women because it's a female predominant disease. So when we look at the adult years, 20 to 50, we find that for every 1 man with lupus, we have 10 to 15 women who have lupus. This is a little bit different in the younger or the older age groups. Now I want to direct your attention to the graph on the right here. And this is showing the 1st-degree relatives to lupus. So given that you have lupus, what's the likelihood that someone who is a 1st-degree relative, sister, mother, daughter, also has lupus? And so you can see in the younger age groups that are on the x-axis, the 1st-degree relatives are very unlikely to have lupus. But as you get into the 2nd, 3rd, 4th decades, you have a peak suggesting that there are some factors likely related to genetics that increase the risk of lupus. Now, the other thing that the study showed was that there is a higher risk for spouses. So given that you have lupus, there's about a 4.4-fold increased risk that your spouse also has lupus. And I think this is really interesting because, you know, assuming that people aren't marrying people who are related to them, it suggests that there may be a shared environment that predisposes to lupus. And I think that's something that warrants much more research. Next slide, please. Now, key concept here, because we always first think about the genetics and the biology of lupus, but then we say, okay, lupus is much more likely to happen in minority groups. Those minority groups don't share common ancestors necessarily. So when we're measuring racial differences in medicine, we are largely measuring the effects of racism. So race becomes biology. Okay, next slide.
Wow.
So race is not genetically discrete. It is not reliably measured or biologically meaningful. So, you know, I try to explain this to people all the time. So, you know, a few years ago, I was dating someone who's Ethiopian, right? I am African American. So it turns out that our genetics are more different from each other than my genetics would be for someone who's from the UK, right? So African genomes are the oldest and most diverse genomes. And so race, even though we would both be considered Black, we would not have at all similar genetics, right? So it's important to know that if there's a difference that falls along racial lines, the likelihood is that there are common conditions that are producing this difference rather than a common set of genes that are producing the difference. Okay, next slide. Okay, so I want to talk a little bit about the history of race in America so that we can understand what this really is and what I mean by race becomes biology. So in the 1700s, when our nation was being born, we had this duality of concepts, right? So we had this nation that was going to be born based on liberty and freedom. And then we also had the institution of slavery, which was meant to be permanent, right? So in order to legitimize this, our founders in the society they're in had to create this caste system based on race. So there were Africans who had the least social capital, natives who were sort of in the middle, and then Europeans who had the most social capital. So it's important to remember that race was this concept that was hierarchical in nature. So there was not different but equal. In the nature of race, we had to have supremacy and inferiority in order to legitimize this system, right? So the idea that racial groups were biologically discrete, as evidenced by these physical characteristics, was born of this. Each race was thought to have distinctive cultural behaviors linked to their biology, and differences among races were thought to be profound and unalterable. So this is really how we justified slavery, subjugation, and native genocide. Next slide, please. So now, how did this get into medicine? And I think, you know, when we all think about racism in medicine, the first thing that people say, you know, Tuskegee or Henrietta Lacks. But I want to make the point that these things don't happen in an equitable system, right? You don't have an equitable healthcare system, and then all of a sudden you have a Henrietta Lacks or a Dr. Sims performing surgeries on Black women without anesthesia, or a Henrietta Lacks, right? So, you know, this idea that race needed to be entangled with biology was very, very prevalent in the 1700s and 1800s. And in 1851, there was a physician, Samuel Cartwright, who practiced in New Orleans. He was very, very well renowned. He was trained at the University of Pennsylvania, which is a Ivy League institution. And the Medical Association of Louisiana asked him to provide scientific support for the racial caste system. So they charged him with this effort to actually document how the races were different on a biological basis. And so there's a website here, you can actually go back and read this, which I did do, and it was very depressing. But I just want to go into some of the themes that come out there and then how they still affect medicine today. Next slide, please. Okay. So, and this is just sort of a general framework. So we have healthcare disparities. All of us live with structural racism. And then we come into this clinical interaction. So a person might experience persistent discrimination. They might have physical and psychological stress, and they're coming with these racial disparities. And then you have clinicians who are often not culturally congruent with the patients. So the clinician might have implicit biases. Their decision-making may create disparities. And their clinical communication may not be the same as with someone who's more culturally congruent. And this compounds negative patient reactions, healthcare disparities, and then ultimately leads to more racial disparities. Okay, next slide. Okay, so I want to turn your attention back to Samuel Cartwright. And on the left hand of this slide, I have some of the things that are written in that infamous manuscript from 1851. And on the right-hand side, this is a 2016 survey of American medicine residents. So these are people who are physicians in training, who will go on to be internists, and some of which who will go on to be rheumatologists, right? So I want you to read some of the things that Cartwright says. So he said, idleness is the most prolific cause of dysesthesia. So Cartwright felt that African Americans had thinner blood vessels, and therefore, unless they were exercising in the form of forced labor, their tissues would be deprived of oxygen, namely their nerves. And so they essentially had decreased sensation to pain. So he says, deprived of oxygen, the blood becomes unfit to stimulate the brain to energy, unfit to stimulate the nerves, causing insensibility of sensation distributed to the skin. Now, I want you to look over at some of the responses from these medicine residents. So this is showing the percentage of people who thought that these things were true. So the first red underline is they were asked, do Blacks' nerves endings have less sensitivity than whites? 20% of people thought that was true. So next, Cartwright says, they are difficult to bleed owing to the smallness of their veins. You can see on the right side, respondents were asked if Black people's blood coagulation was more quick than white people's. Do they coagulate more quickly than whites? And 39% thought that this was true. His brain is a 9th or 10th less than the other races of men. Now, the respondents were asked, do whites have larger brains than Blacks? 12% thought that that was true. The skin is dry, thick, and harsh to the touch. They asked, Black skin is thicker than whites. 58% of respondents thought that that was true. Although the nose is flat, the turbinate bones are more developed, causing the sense of smell to be more accurate. They asked, Blacks have more sensitive smell than whites. 20% thought that this was true. One of the most formidable complaints among Negroes is pulmonary congestion. The Negro's lungs, except when their body is warmed by exercise, are very sensitive to cold air. Whites have more efficient respiratory systems than Blacks. 16% thought that this was true. So what we can see is that these ideas don't go away. These ideas are carried throughout medicine like a game of telephone, and people still carry these biases and they associate with some of the ways in which patients are treated and their symptoms are considered. Now, I want to just pause on this idea of pulmonary congestion, because the other contribution that Cartwright made to medicine is that he invented the spirometer. So in order to prove that there really were differences in lung capacity, he invented this machine that could look at the function of the lungs, right? And he tested white people in society who were generally kept in good conditions and treated like people. And then he also tested enslaved Black people who were kept in crowded conditions, more likely to get infections, more likely to be around soot and smog and things that might affect the lung function. And he found that the Black people on average had lower, about 20% lower pulmonary function, as you might expect in those conditions. Now, with spirometry, we still use this to diagnose things like COPD or emphysema, also to diagnose asthma, which we know more common in Black people. And still today, there's a 20% correction for Black people. So if you are African American, you get a spirometer, your bar for abnormal is 20% higher than if you were white. Think about the implications of that, right? If someone has asthma or COPD, it benefits them to be treated earlier to make sure it doesn't progress. And yet the diagnosis is made at a 20% less sensitivity in African Americans. That affects outcomes. You don't have to be racist. The test is racist for you. Next slide, please. Okay, so let's think about how this affects lupus. So several barriers to lupus diagnosis may be compounded by structural racism. And what do I mean by that? In order to be diagnosed with lupus, you have to have access to care. So you have to be seeing a primary care doctor or someone who's there to hear your symptoms. And we know that lupus disproportionately affects demographics with less healthcare access. So women, younger women, minority women. Diagnosis, you have to say, hey, I feel badly, and your doctor has to believe you. So lupus diagnostic criteria are variable and they're created for research, but physician diagnosis is the gold standard. Imagine if your physician doesn't hear you when you're saying, hey, I have these symptoms that might be suggestive. Symptom variability. We know that lupus symptoms vary from person to person, which may make it difficult to diagnose the person early because, one set of symptoms that a doctor thinks of may not be there for all patients. And in fact, the classic malar rash, which is this butterfly rash, is actually more common in people with lighter skin than people with darker skin. As well, it's difficult because a lot of our textbooks don't include images of people with darker skin. And so it's easier to diagnose because we're used to seeing the patterns on lighter skin. What about co-presentation? We know that autoimmune diseases may present in combination, and in fact, people of minority backgrounds are more likely to have more than one autoimmune condition when they present. And so we may have lupus along with rheumatoid arthritis or Sjogren's syndrome or fibromyalgia. That all can confuse the clinical picture and delay the diagnosis of lupus. Next slide, please. So why is this important? So it turns out time to lupus diagnosis is delayed in ethnic minorities. So this is a study from UCSF out in San Francisco, the CLUES cohort, which is a multi-ethnic lupus cohort. And they looked at 196 lupus patients. And they found that there was longer time to lupus diagnosis in African Americans and in Asians, in people who had lower educational attainment and people who had lower socioeconomic status. Minorities tended to wait over 1 year to receive a diagnosis, and that Asian Americans and African Americans were less likely to be referred to a specialist after they were diagnosed with lupus. So when they looked at referral to a specialist within 3 months, 92% of European Americans were referred compared to 64% and 66% of African Americans and Asian Americans respectively. Next slide, please. So why does this matter? Well, it turns out that people who are diagnosed early with lupus experience fewer flares of their disease and are less likely to have severe manifestations of lupus. So this is a study that was done in 2010, where authors looked at chart records of lupus. So they took time 0, which is the time of first lupus diagnosis, and they looked back 6 months, 12 months for any indication that the person was complaining of lupus or any time that they were tested for an ANA, which is that blood test that helps us diagnose lupus. And then they observed the patients for about 12 months thereafter the diagnosis. So they said, you know, what happened during the 12 months after they were diagnosed with lupus? And what they found was that patients, compared to the early patients in the chart on the left, the late patients in the chart on the right, meaning people who were diagnosed longer than 6 months after they first complained, were more likely to have any kind of flare, and especially more likely to have moderate and severe flare-ups of their lupus. Next slide. Now, it also turned out that patients with late diagnosis were more likely to have more manifestations of lupus and more severe manifestations. So having kidney disease, which we know is an all-important dreaded consequence of lupus, was much more common in people who were diagnosed later. Also having things like chronic pulmonary disease, congestive heart failure, cerebral vascular disease like strokes, all of that was much more common in people who were diagnosed later. So I think what we need to think about, you know, in tandem with thinking about genetics is, how is this disease different if it's not treated early enough, right? We would never expect somebody who had breast cancer, who was diagnosed at stage 3 or stage 4, to do well, even though they got their chemotherapy. However, we don't think about that with lupus. What's the pathogenesis? What's the natural history? What's the difference between someone who's caught early and someone who's caught late? And is that one of the things that we're seeing when we see these different outcomes in minority patients? Next slide, please. Now, a little bit of a word on renal disease, because this is one of the major drivers of increased mortality in lupus. So in the graph on the left, I want to look at, this is all-cause mortality in lupus patients. So these are, this is a meta-analysis that showed that the overall causes of death in lupus were much more likely to be due to renal disease and infection. Also increased mortality due to cardiovascular disease and strokes. Now on the right, this is a Kaplan-Meier curve. So essentially what this is showing, so on the y-axis is the probability of you being free of the outcome. In this case, the outcome is mortality. And we're looking at the curve for patients with renal disease, which is sort of the teal color, and patients, I'm sorry, without renal disease is teal color, with renal disease is the lighter green color. And you can see years on the x-axis, patients who have renal disease are more likely to succumb to their lupus earlier on. Next slide, please. Okay. Now, Who's getting kidney disease? By far and away, the answer is patients of African ancestry. So this is a standardized incidence rate of end-stage renal disease in patients with lupus. And you can see that the rate is 15 times higher for African Americans. It is increased for all people of minority backgrounds, so around 4 or 5-fold for Asian, Hispanic, and Native Americans compared to European Americans. And in fact, it turns out that African Americans are 50% of all lupus patients living with end-stage kidney disease. Next slide, please. So when I gave this lecture before, I used to use this slide, and I'm sure people have seen it before. This, what does health equity look like? And the idea is equality is everyone gets the same stool, whereas equity is people get the height of stool that they need in order to see over the fence. And then I realized this is racist, right? So the person who needs 2 stools is literally diminished compared to the other people. So click, please.
Let's get it back. Yeah. Hold on, my mouse just froze. Yeah. Okay, here we go.
Okay, so this is more of what we're talking about. Inequality is this tree that's tilted to the left side. All the apples are on the left side, so the person standing on that side of the tree gets the apples compared to the person who is not. Equity is both people get the same size ladder, but still systemically, the tree is tilted to the left side, so the person on the right side does not get their apples. Equality would be to give the person on the right side a higher ladder so that they can reach the apples. And justice would be to straighten the tree so that everyone has the same chance at the apples. Okay, next slide, please. All right, so what does it take for us to reach patients of all backgrounds? First is study. We must understand the scope of the problem with quality epidemiologic research, and I would also say genetic epidemiology research. So we need to understand what it is that we're dealing with, and that means reaching populations across the globe of all backgrounds. Listen, we must educate ourselves to understand the unique challenges for patients, especially of minority backgrounds. With focus groups, online platforms, that work is being done, but this education really needs to be bi-directional, not just physician to patient, but patient to physician. Educate. So we have to provide patients with comprehensive information in a culturally appropriate and accessible way so that all people can engage with their healthcare appropriately. And then partner. We know that there are big differences in who's delivering the care and who's receiving care, but our patients have agency. They are very well versed in their own disease, and they're well versed in their community and all the challenges. And so we need to partner with our patients to ensure that we utilize them as advocates, educators, researchers, and true partners. Next slide, please. So just a word on my work in the diaspora. So I've been doing research on APOL1 polymorphisms. It's a gene that is commonly mutated in people of African ancestry, especially West and Central. And it increases the risk of developing end-stage kidney disease given that you have an injury like from lupus nephritis. Now, we initiated this study, Global Lupus Advocates of Discovery. Next slide, please. And we wanted to address some of these problems with global disparities in lupus outcomes. So there are significant physician shortages on the continent. So in Ghana, there are 0.22 physicians for every 1,000 people in the population. There were 2 practicing rheumatologists, and now there's 1 practicing rheumatologist in the entire country. And there is no formal rheumatology training program, though that is changing as we speak. Mortality is unacceptably high in Ghana. So there was a study done by my collaborator, Dr. Jifa Day, who showed that lupus represented 5.28 out of every 1,000 hospitalizations at the major teaching hospital there. And during a 5-year study, the mortality rate for those hospitalized with lupus was 50% over 2 years. Medication options are very limited. So specific medications may be cost prohibitive in the area, and drug companies may not market lupus medications in developing countries. And so there's a heavy reliance on prednisone and plaquenil in the absence of other disease-modifying antirheumatic drugs. Next slide. So we initiated in 2015 a collaboration with Dr. Day. And so this is our whole team. So that's me back in the day, taking blood for the patient. We consented patients, we educated patients, we made our own little t-shirts. That's our team down on the left. And next slide. And we had a great time. Next slide, please. All right. So this is an ongoing study, and we're hoping to learn quite a bit about lupus pathogenesis in the area, how environment and lack of resources affects that, and then how common polymorphisms or genetic differences may affect disease there as compared to African Americans in the New York City area. All right. So thank you, and I will take questions.
Awesome. Let me tell you something. That was an awesome presentation.
Thank you.
Because, I mean, it really touched on everything that we talk about, how far it's so hard to get diagnosed and why there's so much disparity in care. So it was very, very, very good presentation.
Thank you.
Does anyone have any questions before I go to Facebook? Thank you so much, Dr. Blazer. That was really eye-opening.
For sure, yeah.
If you have a question, would you unmute yourself and ask the question? So before we go on to questions, if you all don't have any questions right this very moment, you know, there's so much talk about the disparity in the lupus disparities. With the COVID vaccine and all the COVID issues that's going on, I'm sure there are a lot of disparities there as well. So I do have a question from someone on Facebook. Let me just try and find it now. And she asks, can lupus patients get the vaccine if they have a Guillain-Barré syndrome, if they've had Guillain-Barré syndrome?
Oh, Guillain-Barré, yes, yes. So yes. The short answer is yes, and people with lupus are considered higher risk for COVID-19.
Right.
Also, the mortality rate is higher for patients with lupus, given that they get COVID-19. And so we are recommending that patients get it. Now, Guillain-Barré is an inflammatory condition. So in some people who have had either an infection that precipitates it or a vaccine that is precipitating, they can get inflammation of the peripheral nerves, and that causes weakness and requires infusions. Now, that doesn't mean that every time you get a vaccine, you're going to have Guillain-Barré. It's definitely a condition that you have to discuss with your rheumatologist and your allergist, immunologist. But, you know, it's an idiopathic condition, and we're not seeing it in high numbers in people who are getting these vaccines. So the cost benefit is still in favor of getting vaccinated, but that's something to discuss with your treating provider.
Absolutely, absolutely. Now, can you explain Guillain-Barré is how you pronounced it?
Guillain-Barré, yes, yeah. Yeah, so Guillain-Barré,
exactly?
So yeah, essentially what it is, you know, all of us have a nervous system, and the reason why we can move and feel things is because we have this sensation that starts, you know, you got the brain, you've got the spinal column, and then there are peripheral nerves that sort of branch out like trees and touch every aspect of our body, giving innervation and ability to move and feel. Now, with Guillain-Barré, what you get is this inflammatory reaction. So, you know, you have an inflammatory response, usually from a virus, sometimes from a vaccine, that causes inflammation at those nerve roots. And so it means that you don't have proper innervation to especially the peripheral tissues. So like it's most likely to happen in the lower extremities. It tends to be ascending, so comes up and up and up and up. And it requires hospitalization and infusions of medications that dampen that immune response and allow for the nerves to function properly.
Awesome, awesome. That's kind of rough.
Yes, yeah, it's very, very rare, thankfully.
Yeah.
Very rare.
Yeah.
And
I guess a lot of people are afraid to really even get the COVID vaccine because of our immune system is so overactive, and they're afraid that, like you stated earlier, that sometimes vaccines can cause a flare and things of that nature. So what type of, I don't want you to give advice because we know this is all, you all have to take this back to your own doctor, and this is just for educational purposes. But what do you say to your, people that that have lupus to just ease their minds a little bit about getting the COVID vaccine?
Yeah, so what I say is based on the information that we have available about this vaccine and the information that we have available about other vaccines, right? So vaccines are considered safe for lupus patients, and in general, one of the safest interventions that we have in medicine, right? So I sort of tell them that with medicine, there's always a cost benefit analysis, right? It's always, if I give you this, am I going to make things better for you than if you didn't have it, right? Now, in medicines that we give for very serious conditions when people are ill, like cancers, things like that, we tolerate a lot of side effects because the consequences of not getting that can be dire, right? But with vaccines, we're giving something to people who are otherwise healthy. So we do not tolerate very many side effects at all, right? And certainly not serious ones. So for example, there's a vaccine that was given for rotavirus in children, right? And the safety monitoring board, so we monitor everyone who gets these vaccines, found that 1 in every 300 children who got it had inflammation of the intestines. That was considered completely unacceptable. The vaccine was taken off the market, right? So if we saw a safety signal like this in any group of people, the vaccines would be taken off the market. We have, I think 80 million people who have been vaccinated at this point, and we're not. Yeah, me too. Yeah, right. So we're not seeing these signals, and many of those people are lupus patients. And there's a website called VAERS, VAERS, which is the website for where people can report any sort of adverse side effect they're having from these vaccines. So the CDC put that in place, and they also put in place this other cohort called VSafe, which is over 1 million people who got the vaccines, signed up for text messages, and they were given surveys the first day, multiple times in the first week, and then once a week thereafter, to pick up any sort of adverse event that people may have. In that large collection of people, we are not seeing that this vaccine is causing any sort of undue harm or side effect in any group of people. And in fact, you can go and look up the specific group of people, right? So we're not getting those signals. We're having studies right now at my institution at NYU, as well as WashU and Northwell, a number of places are looking specifically at lupus patients, the immune response, and whether or not people are getting these adverse events, and we're not finding that that's happening. So, based on past experiences with vaccines and also looking at the specific data for this vaccine after tens of millions of people have gotten it, I am very confident that this is safe for our patients.
That's good information. I'm glad that you all are actually following some lupus patients, because of course we weren't able to be part of the study of this particular vaccine. So it's very important that we continue to study it as it goes on, because that's what medicine is. You're studying it as you go. So now the website that you gave again, where you can check, is called VAERS.com. Is that what you're saying?
It's VAERS. Yeah, it's the Vaccine Adverse Event Reporting System. It's through the CDC. So if you go to CDC and you search VAERS, VAERS, it will come up, and you can look specifically at any sort of adverse events that you might get. Yes, there we go. So any sort of adverse events that people are reporting and what's happening with these vaccines. And again, they're extremely safe. Even the adverse reactions. So some people were reporting in the beginning allergic reactions. So that happens in 4.5 out of every 1 million people.
Wow.
Very small amount. Yeah. Even the percentages.
You sit and you look at the information that's coming in from the media, and you think something totally different, but when it's put in those simple terms like you just stated, it really makes sense.
Yeah, well, I mean, the media is there to get attention, right? So, right, like they do well when you're looking. So
Absolutely.
if there's anything that is suggestive, this off example or that off example, then that is loud, and that's something that people are going to pay attention to. But when you look at the numbers overall, very, 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 very safe vaccine.
Yeah. And you know, a lot of people say that any type of medicine that comes through, oh, it came through so fast, or it just was done so quickly. But you know, it is 2021. So if it wasn't
Yeah.
done quick enough.
And I also want to say, I mean, it's true that usually vaccines take, 7 years or so to come through the pipeline. When Obama was president, we had H1N1. We also had Ebola. We also had Zika, right? And so the writing was on the wall for something like a COVID-19. And one of the things that was identified as a big problem was that it takes so long to get any sort of vaccine through the pipeline. So his task force put together a means to efficiently bring vaccines. And the idea was that that could happen in about a year and a half, about 18 months, right? Okay. Now, with this vaccine, so part of the stages for this, so you have the preclinical stage where people, where you understand the virus, you sequence it, you know what it looks like, right? You test it maybe in animals or in cells. And then you have the phase 1 where you're testing whether or not it's safe, the vaccine is safe to give to people. Phase 2 is testing what dose you need. And phase 3 is where you get tens of thousands of people to take the vaccine and you compare whether or not it's efficacious, whether or not it actually prevents disease. Now that phase 1, actually we had a hard start on because we already had, this is SARS-CoV-2, we had SARS-CoV-1, that was SARS, right? We also had MERS. So a lot of that background legwork was already done. And so we were even able to truncate it more, but none of those steps were skipped. And a lot of the intra-phase stuff, in science, we're like, okay, we did this thing. Let's write it up. Let's get some more money. Let's think about it. Okay, let's do the next phase, right? So all of that was cut out so that the phases could go very quickly, sequentially, but we did get all of the information we needed in order to produce this vaccine. So there were not corners cut.
Right. And that's important information to know because what you're reading is not saying that. And it's not saying it as clearly as you stated it. So I'm glad that you were able to do that. Does anybody have any questions here that is on Zoom? I want to be respectful of Dr. Blazer's time. She is so busy and I don't want to keep her too long. Let me see if there's any. You all can just unmute yourself if you have a question. I don't see any more questions on Facebook. And I don't see anybody unmuting themselves to ask a question. So
I have a question.
Okay, Denai?
Yeah. How do you manage when you have discrepancies between doctors? Like one doctor says you've got lupus, and then the other doctor says, well, your blood work looks fine, so you don't. And if you're feeling okay, then you're probably okay.
Yeah, so that is a big deal, especially in lupus, because again, it can be difficult to diagnose. Some people think, oh, if your ANA blood test is positive, then you have lupus, but it turns out that 95% of people who have a positive ANA have no disease at all. And even a large percent of the people who do have something can have something else. They can have thyroid disease, they can have rheumatoid arthritis. So I always say go to a specialist. Make sure you are seeing someone who is a trusted voice in this disorder specifically. And then go to someone you trust, right? If for some reason you don't understand the diagnosis or you have questions, you should have a kind of relationship with your physician where that person can explain why they're thinking what they're thinking, right? Some people have sort of this on the cusp syndrome where they don't fully have all the symptoms of lupus. They may have a blood test that's suggestive, but we're unsure if this is full-blown lupus. Now, those people can be watched over time, and the physician can explain what exactly is going on. So find a trusted voice, make sure you're being heard, ask questions, make a plan going forward so that you're not just, lost in the cracks of things so that someone's really looking at your case.
Absolutely. That was a great question.
Mm-hmm.
And going off her question, a lot of lupus patients have a problem, I don't want to say advocating properly, or just separating from someone who maybe is not as well versed in their case or as well versed with lupus, like you stated, having a specialist. How do you suppose that they can just go about changing rheumatologists and getting someone that they can trust? How do you think they should go about doing that?
Yeah, so a lot of my lupus patients, especially people who are young, I'm their only doctor, right?
Right.
Always have a primary care doctor, because remember that your primary care is your base. So if you're seeing a rheumatologist that you don't feel like is really hearing your case out, you can go back to your primary care and say, hey, I want a second opinion, please refer me somewhere else. That physician will never know. You don't have to tell them, right? There's nothing.
Just ask for yourself, like, and go.
Hey, you're not married. It's not your cousin, right? You can find someone else if you want to, right? So I think that having a primary care doctor who understands you is key. And again, if you don't like your primary care doctor, you can refer yourself to another one. So, don't be afraid to look around. In most places, there are more than one. And then, in people who are living in, there are certain areas where there may not be rheumatologists, right? Rural areas, some urban areas. And so I say go to trusted sources like the Rheumatology Research Alliance, the Lupus Foundation of America, the Arthritis Foundation, the American College of Rheumatology. They have a list of their membership. And so you can go there and either connect with other patients or connect with physicians who are listed and see how you might go about getting a referral.
That's good information, especially going to get a referral, because sometimes I do get people from different areas that might come by and say, I have no doctor, and can you refer me somewhere? Not I can only refer you to mine, but if I can go to those places, then I can have a place to show them. Thank you for that. That was a good.
For sure. Yeah, good. There's the lupus. So on the American College of Rheumatology website, there is the lupus. Oh gosh, I'm going to send it to you afterwards. But essentially, there's a area specifically for lupus patients where you can go and get connected to other patients and then also get resources like this.
Awesome.
Yeah.
And that's great, because I think sometimes we rely on each other so much, and sometimes we really need to go somewhere that has all that information right there and stop reinventing the wheel. It's part of, advocating for yourself and getting the information out there to others as well. Does anybody else have any questions? We're going on an hour.
Lupus Initiative.
What is it?
The Lupus Initiative.
Oh, yeah, I've heard of that before.
Yeah.
Okay. There are so many different organizations out there that are helping, and every organization has their own little niche.
Right.
And it's great that you can go to different areas and get what you need and actually disseminate that information to other people. So thank you for that.
For sure.
Does anyone have any other questions? Let me see on this. I do have someone that's on Facebook. Estella is saying that it is a great discussion, which I totally agree with. You have taught us so much today in this short period of time, and we so appreciate it. I think the only other question that I have is, what advice do you give lupus warriors to minimize symptoms and minimize flares and things of that nature? Just from a doctor's perspective, what type of advice do you give lupus warriors?
I say that lupus is the kind of problem that is chronic and unpredictable and causes a lot of anxiety. And anxiety, stress can lead to flares. Not just because the stress of it can lead to flares, but also because if you don't know how to take care of yourself, you're sort of frantic about it, you may not take your medicines the way that you should, or right. So I always say that lupus is a one day at a time problem, and that I just think about it as any other life change, right? It's like suddenly having another child, right? you are going to have to maneuver. You're going to have to take this into consideration in your everyday life, but it doesn't mean that you can't have a full and fulfilling life, right? It's just something else that you have to consider.
Absolutely.
So, it's all about getting your headspace where it needs to be so that you can react and you can make sure that your care is appropriate. And then I also say, don't do this alone. I always find that lupus patients, so first, lupus patients look fine. And in fact, I feel like for some reason, only beautiful women get lupus. So it's always a scenario where people look great and no one around you knows you're sick. It's this invisible disorder, but you're tired. You can, you're struggling through your everyday life. And if people don't know what you're going through, they don't know how to support you. So I always say, especially my newest diagnosed people, I'm like, bring your family member, bring your mother, your cousin, your husband, your child, so that I can explain this to them too. Because when you can't, they're picking up the slack, and you have to have that support around you.
Absolutely. Absolutely. That is good information. Good information. Support is definitely important. And a lot of people are, I guess they're afraid to say that they're sick, because you don't want to be judged because you're sick and you don't want to worry anyone because you're sick. So, but I do agree, most beautiful women have lupus.
No, but and also I think people just stigmatize, I hear so much from my patients, they get it, they're young, they're in their career, and all of a sudden they can't do things that they used to do. And they're like, oh, I thought I was just lazy. Oh, I thought I just needed to try harder, or, and I think that kind of a thing, you have to really
separate
take the idea that life is different now. And that's okay.
Yeah. And that's important. What you just stated, life is different now, and that's okay. Right. Things change daily, so we just have to roll with the punches and not let our careers or things that we did prior to diagnosis really defined us. And we can't let lupus define us either. So
absolutely.
Awesome. Someone stated, do you
believe in seronegative lupus? I do.
Okay. Did you see? Yeah. I couldn't read that, right?
Yeah, I do. Yes. Seronegative lupus is a thing.
Okay, what is seronegative lupus?
Okay, essentially, we talked about that test, that ANA test, anti-nuclear antibody. And that is a blood test that shows us the kinds of proteins that the immune system is making. And those proteins should be directed against the nucleus, which is sort of the middle part with all the DNA of your own healthy cells, right? Now, there are some people who have all the symptoms of lupus, but that test is negative. On average, it's about 5% of lupus patients. That is real. So, the thing is, ANA is it's a non-specific test, right? We think we know all of the components of the nucleus that these antibodies can bind to, but we may not be testing for all of them. And some people can have just rarer ANAs that don't come up on the laboratory test. Also, some of these particles that are sometimes in the nucleus and sometimes in other parts of the cell may be the ones that are inciting this immune response. So yes, that does happen. Lupus is a clinical diagnosis first. We should not think that the ANA is the end all be all for lupus diagnosis.
Right. So you use the ANA, the ANA test, as well as those criteria.
Yes.
And base that on your actual diagnosis.
Yes, so criteria first. The blood test is supportive. It is not the
diagnosis. I got you. That's very important, because people think that the blood test is the final. This is what you have. And it has to accompany those criteria to make it whole.
Absolutely. There are a ton of people who have a positive ANA who don't have lupus. There are some people who have lupus and don't have an ANA. Right. The test supports our diagnosis.
Right. That's the time that you go to the doctor and the doctor says, yeah, your ANA is great. You should be fine. And you're crippled. You can't even walk. You can't even think straight and things like that. So yeah, that was a great question. Mm-hmm. Thank you so much. Thank you so much for coming on today. I so appreciate you taking moments out of your time. I know you've been busy. You've been doing the circuit, and I've been following you all over the place because I just love the information that you're giving. It's so educational, and it's so important for us to be educated about lupus in order to fight it, you know what I mean? So that we understand what we're going through, we understand our own bodies, we understand how to advocate for each other and ourselves. So it was so great that I was able to find you and get your information in. What I do want to say is that everyone who is watching, just realize this is just for educational purposes. I don't want you to take anything that Dr. Blazer has said and do it on your own. I advise you to go to your doctor and have your doctor talk to your doctor about it, and then deal with that with your doctor. Everything that was presented today was just for educational purposes and for you to be knowledgeable about what lupus is and what's going on with the disparities, different genetic issues that Dr. Blazer has talked about. Dr. Blazer, how can we support you? And this is our last question for the night. How can we support you in your work in Ghana?
Wow. Well, I haven't really thought about that. I think just in general, you know, it's a lot of times when we don't have enough people who are involved in research is because people either don't understand research, don't feel just very almost exploited if they're involved in research. And I think having people who have the best understanding of their disorder and then what it takes to get it better is a group of people who are able to then engage in research. So I think as you educate yourselves, as you understand the process and the process of research, then you're able to take opportunities to participate when you can. So I think, you know, self-advocacy is the most important advocacy for me.
Right, absolutely.
Other opportunities, maybe I'll reach out.
Okay, definitely do, because I definitely want to support you in that, because I get a lot of people from Africa contacting me on my site. So I definitely want to be able to give them your information and let them know what's going on in their country.
For sure, yeah, for sure. And there's an African League of Arthritis, the AFLAR. African League Against Rheumatism, which it's a AFLAR, AFLAR. And that is an organization kind of like the American College of Rheumatology, but for on the continent. So there are multiple countries with rheumatologists who are doing work in lupus there. So that's another resource for people who are interested in rheumatology.
Awesome, because I just spoke to someone in Nigeria that was looking for something, for information. So I'm definitely gonna pass that on.
Yeah, in Nigeria, there are a ton of rheumatists. So one of the people I collaborate with in Nigeria is considered like the father of rheumatology in all of Nigeria.
Oh, really? Okay.
Yeah, he built the program, Professor Adelowo, built the program in Nigeria and then trained people from different, like doctors from different states in Nigeria and Lagos, and then also South Africa, and then sent them back to their states. So Nigeria is one of the sub-Saharan African countries that has like the most rheumatologists, which is yeah. So they have and they have an academic program and everything. So it's the program's very rich there.
Well, that's awesome to know. That's awesome to know. I will definitely pass the information on. If there are no other questions, I want to thank you so much for coming on tonight. And I hope that you have a great rest of your weekend, that you can rest and not have to do any more talking and just relax a little bit. And we so appreciate you coming out tonight and giving us this great information.
No problem. Thank you for having me.
All right. Thank you, everybody, for tuning in. We will be stopping this event at this time. And if you have any further questions, please shoot them to me at lupusincolor@gmail.com, and I will pass them on, and maybe Dr. Blazer will answer them later. All right. So bye, everybody. Thank you for coming. Thank you so much, Dr. Blazer, for your information.
Thank you.
Thank you.